My talk will be a little bit less with graphs and statistics, more conceptual, and more related to a critical period that we are passing now when neuromodulation is being developed. So neuromodulation is a general name for brain pacemakers. But before I start, and you don't need to register it, I want to know who is my audience. Do we have a psychiatrist in the audience? Okay, one. Journalists? Lawyers? Okay. No, I have to be careful with what I say. If someone is offended from something that happens in this talk, then psychiatrists especially, then I apologize, and that you can register. Okay, so we are in a very exciting period, I think. And what you see here is to exemplify neural dust. It's not just all we are is dust in the wind, but neural dust. Now, let's take an example of the technologies of neuromodulation related to neural dust that exist today, and they're probably the future. These two guys, they developed these particles, which are very small. They're not nano, but they're very small. And they can respond to ultrasound energy from outside the skull and generate electricity. And also, they generate a kickback signal, so they can become like electrodes that measure activity, but also electrodes that inject electricity to the brain. So they can be injected into the brain via CSF or blood, and there are these transducers, small transducers that generate the ultrasound activity, so you can control brain activity from outside, and you don't need any drilling any holes in the skull or putting any electrodes. You know, when you think about neuromodulation today, you think about a brain pacemaker, you think about something with electrodes, but here we have the beginning of technology that does not need it. This woman here, she's called Paulina Nikiva. She's developing nanoparticles, metal nanoparticles, which are injected into the brain and using some genetic technology attached to the calcium channels in the neurons, and with very small, low electromagnetic field, she creates hysteresis, which means there is nano heat at the level of the channel opens, the neuron fires, and you can control neural activity from outside without really needing any more technology than that. It could also help direct where the particles should be. We're using magnetic fields. We have this technology, which is very developed now in Israel and in Rambam. We have this device. It's called focus ultrasound. In the past, also now, it is used for ablation of cancer, but now there is new technology where you can direct the ultrasound activity, and it's actually a mechanical activation of neurons, so you can activate neurons from outside without needing to have invasive technology. Everyone knows the TMS and BrainsWay, the company that has made a lot of commercial success. Electrical magnetic field can activate neurons from outside, and this is another technology. This is a very interesting technology, which is very, very primitive. Actually, what you can see is that we have anode and cathode electrodes placed on the skull, and a small amount of electrical energy passes through the skull. Most of it goes away on the scalp, 60%, but 30 to 40% goes into the brain, and actually does something very interesting, which it has an anode and cathode. Underneath the anode, you have depolarization, which increases the ability of the neurons to fire. And under the cathode, you have inhibition, hyperpolarization. And what is interesting is that it doesn't really activate neurons. It lets the neurons fire as they would anyway, but makes it easier for them, meaning that their computation could be made easier, and you know, fire together, wire together, the plasticity also increases. So this device is very primitive looking, but it's very interesting. It shows a lot of promise as antidepressant and also as stimulator of cognitive functions. You can put it in various ways. There are various settings. I will not go into it. And it's called TDCS. And you also have a TACS. That would be what I showed you before is direct current, and this is alternating current. So when you have alternating current, you can actually give pulses to the brain, and you can actually generate a rhythm, which we know that different rhythms relate for different cognitive functions. And this, for example, is an example of a device sold like that on the web for anyone to use. It's not a medical device, but you can use it at home, buy it, and it's very safe. This is a traditional brain pacemaker that we know that is used for Parkinson, where you actually insert an electrode, you drill in the skull. This is, for example, in epilepsy, a feedback loop. You have a sensor, and you have an electrode, and you have the ability to monitor the activity, for example, in epilepsy, and give a feedback loop. And this feedback loop was applied recently in San Francisco to 2 or 3 patients with depression. They monitored like beta activity in the hippocampus, and they related to depression, and they inhibited it, and depression went away. So it's recently also thought of as a cure for severe depression. Everyone knows Neuralink. Probably this is technology that is used for brain-computer interface, but it's also relevant for psychiatry. And this is the famous robot that transplants, I think, 20,000 electrodes in 1 hour, and so the technology is improving. This is an example of using this technology to control the computer. Optogenetics is another technology not so much relevant for patients in the original mode, but is very relevant for research, where you can use molecules that respond to light, and they attach to the calcium channels, and they open them, and you can actually control brain activity very selectively, and it's very, very relevant for research. For clinical use, it's not new. We know that we have the ECT, the electrical treatment that we have in psychiatry from many years ago. This is the first device. We also had various attempts to intervene in the brain in the past, like in this case where there was an attempt to directly disconnect the frontal lobe from the rest of the brain. You can do it by using an ice pick, putting it into the skull and moving it. You can see the procedure. This was used until the 70s in America. And this is Delgado. Delgado, he transplanted an electrode in a bull. He wanted to control aggression, and he could stop the bull in the corrida using a transplant in the frontal lobe. He also did it on humans. This is taken from a video that you can find on YouTube where it describes how he did it in the 70s and the 60s. Okay. So we are in a very interesting period where we have, as you can see, a variety of technologies, and there are more. I didn't cover all of them, but you can get the impression that we have what we can say in general, a brain pacemaker like a cardiac. Now, let's compare it to cardiology, okay? So you have a cardiac pacemaker which corrects, let's say, arrhythmia, cardiac arrhythmia, and eliminates the symptoms, let's say the chest pain. So we have the symptoms on one side, we have the pathology in the middle, and we have the therapy, the cure, okay? So now we have these brain pacemakers, and we have, in psychiatry, we also have symptoms. Like chest pain, we also have symptoms, like depression, let's say, okay? And now we also have the technology, okay? But there is something that we are missing. We don't know the pathology. We don't know the etiology. Now, the fact that we have the technology puts psychiatrists in a very stressful condition, I think. They should be really stressful because they're with their back to the wall. Why? Because without knowing the etiology, our field looks very bad, I will say. Okay, let's take a clinical situation in psychiatry. A patient comes to the psychiatrist, says, "Doctor, I'm depressed, I'm sad, what do I have?" The psychiatrist will say, "You have depression." The intelligent patient will think to himself, "I just told you that. What added value can you give me?" You expect, like, you come to your family practitioner with a stomachache, that he will do some kind of diagnostic process, and he will tell you you have appendicitis, or you have some other cause that causes the symptoms. Okay, so if you have appendicitis, it's a location in the body, and what happened to it. Okay? But when you say depression, is it a location in the body? Linguistically, it's not. Is it some kind of mechanism? No. So we are in a very severe condition. Actually, because of this, there were many people who thought that psychiatry should be taken out of medicine. Every other colleague of us is an expert in an organ, okay? Cardiologists, cardiac system, gastroenterologists, and so on. What are we experts of? You don't hear the term brain, brainitis, brainosis, or anything in any mental disorder, depression, anxiety. So we are experts of phenomenology, okay? This is the only thing, but we would like to be experts of the brain, and why? Because this is the organ of the causes of mental disorders. So translating phenomenology to brain disturbance is something that has not been done yet. Now, for many years, this thing has not been done. For many years, psychiatrists didn't bother with that. But what I think personally is exciting in this period is because of the technologies that are emerging and the knowledge that's emerging with these technologies. Let's say you want to stick an electrode in the brain for a patient. You have to know where, when, why, how many, inhibition, excitation, what's the algorithm. Actually, Paulina Nikiva, she was in Israel, she told me that her technology will be ready for us in a few years, and she could correct arrhythmias or whatever disturbances in the brain. And I'm a psychiatrist, I'm a specialist, I know what's wrong with my patient, and I will tell her what's wrong with the patient, and she will help me correct it. So we don't have etiology. Now, there is enough knowledge, I think, to begin and build such an attempt. And with this, I will end the talk. I'm not just talking, saying, oh, we need to know the etiology. Let's try and build one in a very, very quick and shallow overview. The brain is a system. A system has units, and units are connected. The brain has neurons could be units, or regions could be units, and pathways or synapses could be connections. We know that the brain matures in a certain way. We know that in the beginning there are many neurons, but no synapses. Then we know there is an over-connectivity of synapses. And then we know that there is some kind of pruning. And these are related with the development of life events and also with mental functions. In the beginning, we are like babies. We see and perceive the world as babies. Then we are teenagers, or in Hebrew, tipesh esrei, so we are stupid. And there is a lot of mess with the organization of the synapses, and then the maturation becomes with pruning. What is pruning? Pruning is making the brain a small world network. We know that the optimal brain is a brain of small world activity, where you have a balance between nearby connections, as you can see, the blue ones, and faraway connections. When this balance is disturbed, then the system tends to disturb. So this could be something like a correct arrhythmia if we compare to cardiology. We also know that the brain can represent information, actually represent the whole world, with attractors that represent information, and this information evolves as we develop. We also know that the mechanism of incorporating this optimization of representations has to do with the Bayesian brain. The Bayesian brain is the brain that predicts what's happening in the environment and adapts to it all the time, continuously. We have a map of the brain as a small world network with the hubs and hierarchy and everything that it comes with this kind of organization. And here below, we can see what can happen if this balance of connectivity is disturbed. If we have many connections, let's say if we have a few nearby connections and many faraway connections, the system becomes unstable and random, and we can also calculate more higher level information about the brain. And when we have many nearby connections, so this balance, we see it in the clinic when the patient becomes disoriented, disconnected, psychotic, what we call, or becomes deficient and with reduced activity, okay? We know about the brain that the brain acts as a set of networks of organizations, the executive network, the default mode network, and salient network. And we know that these networks combine between them their activity, they are activated in a certain dynamics. I don't have time to go into it, but we know much about this information. We know about the time scales. We know that psychosis is a millisecond range scale. Depression and anxiety is weeks and days, and personality disorders are a lifetime. So now we can start building a brain-related diagnostic system. On the one hand, we have schizophrenia, anxiety, depression, and personality. We can match the time scales that we talk about. We can match the networks. We know that different networks are relevant to different phenomenological aspects of psychiatry. And here we are. We can build a brain-related, complex system physics, new diagnostic approach to mental disorders, which will give us the possibility to know what we are doing when we are entering the brain and sticking electrodes in it. That's it. One example for something concrete, okay. If you scan the literature, there is a lot of literature talking about disconnection syndrome. These are papers back from the 80s, and till today they showed it repeatedly. Disconnection syndrome in the clinics is correlated with psychosis. It's also intuitive. Different brain regions act independently from each other, and in psychosis you have a lot of confusion, which means random activity, people hearing voices, auditory perception disconnected from the rest of the brain. Now, this connectivity is controlled by hubs in the brain, and one of the known hubs is the frontal lobe. And in the frontal lobe, you have pyramidal cells and you have interneurons. And we know that you can control the interneurons, let's say, with optogenetics, for example. This is the work of Ofer Izhar from the Weizmann Institute. By manipulating the interneurons, he manipulated the hubs. And the activity of the whole brain goes into the frontal lobe and goes out. And by manipulating this threshold, he could disconnect or overconnect, and he shows it using gamma EEG activity. So you can enter into a hub. If you know what you're doing, you can control the disturbance. So hopefully what is coming next is that a psychotic patient comes to the emergency room, we put a device, we detect the disconnection dynamics, we intervene in the interneurons, we play with it a little bit, we rebalance it, re-optimize the brain activity, eliminate the symptoms, and the patient goes home. So this could be a concrete dream, a fantasy that might happen in your lifetime.
Sorry. We're really short. Time is a short one. I'm not, going back to the beginning of your presentation, I'm no lawyer and no journalist. But beyond the technical part of the presentation, there is a psychosocial issue I'm trying to see here, entering sensors that are not only sensors but actually can activate parts of the brain into the skull cannot turn the human into possibly some kind of an externally controlled being, and who knows who gets the hand on the controls?
I get these questions a lot, and so I'm ready with the answer. I'm a psychiatrist. I want to cure my patients. I limit myself to that. People ask me about, what do you think about world peace in psychiatry? I want to treat my patients. I have patients, and I want to treat them. I want to cure them.